All right, good morning, everybody. These are the survivors. 4 days and counting. Welcome back. I hope everybody had a good evening yesterday. It was fun. It was great. Yeah, I don't know who closed it down, but it wasn't me. So just so you know, when I woke up this morning, we're about 10 miles north of here, and there was snow on the ground. It was really not, but I think it was melting. So we thought that we would just basically spend the next, hour and a half or so with some of our faculty that you heard from during the last few days to talk about pretty much anything you'd like. So questions, clarifications, some interesting ideas that might have popped to mind, and we'll engage, they'll probably start talking to each other or with each other and creating new projects, and it's sort of a representation of some of the ideas. So also an opportunity if there are things really that you didn't really understand that you might have jotted down to clarify. So it's meant to be really freewheeling. There's no agenda. It's really just an opportunity to engage and close out the meeting. We do want to be out of here at 11, but if we finish sooner than that, that's fine. Folks are heading out to the airport, and yeah. So anyway, and Jen is waving her hand at me. So there you go. All right. Yep.
You can stay here. Hey, everyone. I just wanted to take a special opportunity on behalf of all the families and LFSA. David, you have to come up here for a minute. It's a little smaller crowd, but it's from the heart. So I just wanted to tell you, we just want to say thank you so much because you have no idea how much time and effort David put into putting this conference on, and the fact that we're allowed to share in it, and I know it's a scientific conference that it started that way, but the fact that we can share in this and be part of this and help in any way that we can, we are just so grateful from the heart. So thank you so much. So we have a gift for you. We got something special because we're always taking him away from his family, so something he can use with his family. So
great. Thank you so much.
And then you got your special bag.
Ooh, cool.
Yeah, it's got the LFSA. Yeah, it's a little coveted. It's a little coveted. Yeah. Thank you so much.
Yeah, you're welcome. Thank you. All right. Okay. So, okay, excellent.
To use this thing, or can I just talk? So I feel like every scientist said, I'm so grateful for your talk. So I'm so grateful for this conference. I have a specific question in regards to my family, but maybe it'll apply to somebody else. So my son had, at 7, was diagnosed with an undifferentiated embryonal liver sarcoma, and it went through 9 months of chemotherapy and is doing well. For follow-up, we do dedicated chest, abdomen, and pelvis MRI. And then once a year, we do the full body with the brain, along with the dedicated abdomen, chest, and pelvis. But my question was, some people brought up that sometimes the MRI is not as specific for the lung as maybe what it could be, and that maybe throwing a chest CT scan in there might be a good idea. And I'm wondering if people had thoughts on that regarding, I don't know, because that's where his sarcoma would go to if it were to spread. And is the dedicated MRI specific enough, or would a chest CT scan maybe be? So basically, I tell my oncologist what I want them to do, so I just want to make sure I'm telling them the right things.
Hello? Hello, hello, hello.
All right. So I think that that CT is indeed better to catch spots in the lung, but on the other hand, CT is also involving radiation. And the radiologists are getting also better in seeing spots in the lung using MRI. So I think that in your case, I would probably just leave it like it is and talk, and because you have slightly worse mode of detecting it, however, you have less radiation. If there is something significant, you would probably also see it on the MRI. So I'm not a radiologist, but they are actually right now moving into looking at lung lesions using the MRI also. So that's kind of new and developing, but I think it should be okay. It's not 100%, but I would just leave it like it is. My recommendation, personal, without knowing the case.
Would it be
detail.
worth having my oncologist ask the people who do the scans if they feel comfortable?
It would be good if they speak to each other through tumor board. That's always very helpful. I think that's good.
And so if they said that they were less confident in it, maybe then.
I mean, I think, if you use CT scans, you also have the risk that you employ radiation. So I think doing it like it is fine.
Okay, thank you.
And I wish your child all the very best.
Yeah,
Do you want to say anything, David?
Did you want to follow anything to that?
Well, I tend to be more of a leukemia lymphoma specialist. I would agree with Christian, but I would defer to you because you're really the solid tumor expert compared to me.
Yeah, I think here it's a great question, and we do, I think, as Christian said, we do struggle with it. It's not a very clear answer. Here I tend, and I think my colleagues tend to use, at least in this context, the MRI. We have a great deal of confidence in, you saw a couple of our radiologists, in their ability to identify something that if they feel needs to be followed up, that we could follow it up with a dedicated CT. Just as a general context, in the context of at least pediatric sarcomas, once the kids get a certain period of time out from their end of therapy, we actually don't use CT anyway. We use chest x-rays. And if something's found there, then we just go back to CT.
Chest x-ray on leukemia or just
In general.
Would you use chest
So some have said, the radiologists say when the dose of radiation for a chest x-ray done every 6 months or something like that is really pretty tiny. So I'm not advocating for that if the MRI people are confident that the MRI is sufficient to be at least as good as a chest x-ray. So we would do that.
Can I ask one more question? So there's a debate in our hospital on when they do the MRI. So half of the people want him to be sedated so that they can have him hold his breath for a full minute while they do the scan, and then the other half of the anesthesiologists don't agree with that. So it depends on what anesthesiologist we get to how they work it. Do you have an opinion on that at all?
No, it's too bad we don't have our radiologists here, but that will happen at any hospital, honestly. I mean, the anesthetists do have their different practices, so it's a challenge. The one advantage for sure of being under anesthesia is that you can get the breath holding. A significant disadvantage of being under anesthesia, aside from the fact that you're under anesthesia, is that the lungs tend to collapse a little bit. Because of the way the air is moving, and so that you can, often when we see even CT scans, frankly, of kids who are under anesthesia, is the lung airways collapse a little, and then there can be some challenge for the radiologist in determining, is that collapsed lung or is it actually a little spot? So the ideal is having the lungs awake so that there's good air flow. Yeah. Yes.
I just actually making a question in the name of one of the Brazilian patients. She just discovered that her baby son has LFS, and she was a little bit lost about the Toronto protocol, and she wanted to know the differences during the stages of the child's growth. during the ages. If they have to do the MRIs, just the same thing as a young child or a teenager, if there is some changes during their development for the protocol.
So it's a great question, and I might defer part of it to Mary Isabel, being the Brazilian. No, but you're the Brazilian expert. We could join forces here.
Thank you, Yasmin. I think, as I mentioned during my talk, Thank you, Yasmin. So, as I mentioned during my talk, now we're making the first scan as soon as the child or the baby gets diagnosed. And the best thing is really to scan every single year, regardless of what age started. So we know MRIs have no radiation, so there's not a big impact. Of course, there's the impact of anesthesia. So it needs to be done in one of the very few centers in Brazil where they have the expertise to do a whole body MRI, where they can really shorten, because I've heard around in Brazil of people who are doing the head separate than the chest, then the limbs. And we should really have a center where they can do it all at once, and the rapid whole body MRI, not just whole body MRI taking 2 hours.
For the baby.
For the baby and the head also. You have to have a brain MRI at the same time, especially for kids, because of the high risk of brain tumors as well.
So, but there are other protocols besides,
So-
like ultrasound still for the babies. Everything that we do for the grown-ups, we also do it for the baby.
So you help me if I'm
Yeah,
wrong?
I'll help you here.
So you, yeah.
So the simple answer is, at the moment, yes. There are some minor modifications. So, for example, adrenocortical carcinoma, extremely higher risk in the babies until they're maybe 10 years of old, 6, whatever, extremely rare in the context of Li-Fraumeni as an adult. And so there's some discussion that, okay, we probably don't really need to look for ACC in adults. Similarly, the breast cancer is not a risk until, at least adolescence. So one could argue, and we don't recommend any breast imaging specifically until the girls are older, at least approaching puberty or after puberty. But for the whole body MRI, because it's kind of covering a whole bunch of things, that's kind of consistent from basically as soon as the diagnosis is made until whenever. And, hopefully in the next meeting in a couple of years, there'll be more data from circulating tumor DNA and even from all the studies that are now going on in terms of using this surveillance protocol. People are using, you've seen from the French group and others, some slight modifications. And as those data mature, I think we're all hoping that we can be more refined in our surveillance depending on the different ages. But at the moment, for her, for you, we would still recommend pretty much the same thing across the board.
Okay, thank you.
And also, it would be interesting if she could have really cancer genetics counseling for her to help her cope with all that. And the child should be seen by a specialist every 6 months at least to get the physical exam. And also, it's important to have the ultrasound 6 months after the whole body MRI, just as a control. And also, we do blood draws. For instance, in January, then in July. In the Toronto protocol, in the beginning, they used to do it every 3 months, right?
Yeah, we still do it in Toronto.
Yeah.
But some places move it out a little bit. I think some of my own patients are here and they know that we still push about every 3 months. I mean, I don't make a big deal if it's 4 months. Sometimes, people have weddings and, school events and things, so clinics get shifted. But the consistency is actually something that I think we're...
In our case, we changed it because most of the patients, the parents, used to really react very hard on it. They used to say, well, I'm going to be living in a hospital most of my child's infancy, so I don't want to do it. So we just glued together every 6 months, a visit to the hospital. And we noticed that whenever there was a tumor, at least in our cases, we were able to diagnose in time, but maybe that's not the case here.
Okay, thank you.
Thank you.
Other questions? Yeah.
Sorry, I have one more question. So you said something about as the girls reach puberty. So my question is, once your child has developed breast tissue, is the full body MRI scan good enough? Okay, so what age are they considered an adult and switch to having breast MRI versus just the full body? And
Right.
could you offset that?
It's an amazingly good question, and we don't know the answer to that yet. We're transitioning and starting to add we don't really do the dedicated breast MRI until they're a little bit older, sort of around 18, and that's kind of being consistent. But I know a couple of other colleagues have found kids less than that age, about 16, with carcinoma of the breast, like the phylloides form, which would suggest that we should probably be doing dedicated breast imaging. Now, it can be detected, as you heard, on the whole body, but there is a possibility of missing it on the whole body too. So I think I'd be interested in what you think as well, Kim, because you're in the pediatric space.
So we start at 18 unless there's a family history of early onset breast cancer.
Let's say a mother got breast cancer at 19, we had one. We had another one who had breast cancer at 21. Then we would start screening in the family. We would start screening in the family 5 years before the earliest age of onset. So if someone in the family had breast cancer at 21, we would start at 16.
16?
Yeah, but generally we do 18 unless there was already an early onset breast cancer in the family, at which point we would start about 5 years earlier than that.
So if I have an aunt that was 21, then
We at my institution would probably start screening in the family a little earlier than 5 years earlier.
so by age or by development of breast tissue?
Well, there has to be something to screen, right?
Right,
so,
right.
I would and a lot of girls nowadays do develop breast tissue at
Sooner.
14, 15, 16. So I think if there were, I would consider doing it. At our institution, it's a children's hospital, so we have a close alliance with the Adult Cancer Center in our city, and so you'd have to find an adult facility that would be willing to do the breast MRI. It's obviously a different kind of machine that you'd use. But I would personally consider screening earlier if she had sufficient breast tissue and if there was a history of early onset breast cancer in the family. So at 21, say, we would probably start at 16, as long as she had sufficient tissue. But I would like to hear your opinion too, and others.
I think the awareness is important too, the awareness, breast cancer awareness, and also the self-exam is also important. Yeah. To teach how to do the self-exam.
Yeah. So it's interesting you mentioned, Kim, the age of onset, because we actually have written, I think, from the AACR workshop, there are some, like colonoscopy is based on the youngest age, but that assumes there's actually a family history. And we've had at least one where it's a de novo mutation. There is no family history in the breast cancer. So, I think we'll be having more discussion of how the protocol evolves, but I get a little bit concerned sometimes myself of using family history entirely as the driver of when we start the age of onset, because that means that the 25 or 15 or whatever percentage of patients that have a de novo, a new mutation with no family history, we wouldn't be doing it, and we could be missing things. So moving target, but I think the general recommendation at the moment is you start as early as your institution is capable of starting, and if there's a strong family history, for sure. Yeah.
Have you seen any, I've heard of several people that have had rheumatoid arthritis and have had cysts in their extremities, and their doctors can't figure out what is going on with them. Have you seen, in their LFS patients, have you seen any correlation with cysts and rheumatoid arthritis with patients with LFS? Because I'm getting a lot of questions like that.
So, as a matter of fact, Arnie, Jerry, and I were at breakfast talking about it. That's exactly. So I think this is probably one of the most amazing things of this symposium, among many things, is at least 3 individuals came up to me and says, LFS, I have a mutation, whatever it is. I had cancer, and I haven't had the cancer hasn't come back. It's 10, 15 years already. I happen to have rheumatoid arthritis developed, and I'm a little bit of methotrexate, and my cancer's not back. What's going on? And I have at least a couple in my own practice like this, and we've been trying to figure out exactly where it is. And I think Arnie's talk yesterday gave us some really interesting ideas that may not be a totally random association. So I'll let him do the talking.
I'll try to be as explanatory as I was yesterday. Actually, this morning at breakfast, David and I planned an experiment based on the patients he had with rheumatoid arthritis, because the question that you're asking is very relevant. So I was presenting what is best considered, for the present time, a hypothesis, but for which there's growing data and for which there's really strong support in cancers that develop in non-Li-Fraumeni patients, in the general population. And that is that the immune system can, under certain circumstances, recognize the mutations that occur in genes in cancer. And when it does, the immune system can attack the tumor and kill it. And that means that, in fact, there's even not an unreasonable hypothesis for which there's growing evidence that tumors may arise that we never know about, that the immune system clears, and it just never comes to the clinical level to even look at. So there's this growing evidence that that's playing a role. The immune system is also intimately involved in autoimmune disease, one of which is rheumatoid arthritis. So if the immune system starts to recognize a tumor, then a lot of hormonal changes occur within the immune system. It's actually a remarkable system of what's called homeostasis, which means there's communication between cells that keep you safe from your own immune system. And when you get rheumatoid arthritis, it's your own immune system attacking your own cells. So there were 5 individuals who were long-term survivors of pancreatic cancer who we managed to demonstrate are likely long-term survivors because their immune system is still 11, 12 years after they've had the cancer, keeping the tumors in check. So they've gone through chemotherapy and surgery and come out the other end. They get screened actually very much like Li-Fraumeni families. Once a year or once every 6 months, depending on how long they've been out, they're screened. It's all negative, but the immune system is still active there, suggesting that maybe there is a bit of tumor tissue there that can't be seen, and the immune system's taking care of it. And the way we actually tested that was we got blood from people 11 years after they had the tumor, and it still reacted with the antigens and the mutations that were in the tumor, one of which was a p53 mutation, right? And of course, much like the fatigue I hear about in your screening procedures, these people don't like to go and get called back to Memorial Sloan Kettering to give blood for some experiment that they don't know much about. And so we actually hired someone to go out and collect the blood. So that most of the patients are in Long Island and Memorial is in Manhattan, and people go out. And when the nurse practitioner came back after drawing blood, came back with the fact that the person had an autoimmune disease, and the autoimmune disease, much like rheumatoid arthritis, not exactly, had some incapacitations and so forth and so on. And so we begin to see some coincidences between an active immune system that might be taking care of a tumor and at the same time an autoimmune disease. Now, that's speculation, right? But you have to have a hypothesis to test it, right? And so we're going after that, and that's why these meetings are so extraordinary, right? Because I've heard now of many examples, and it makes the hypothesis stronger if it's repeated in several people. But furthermore, these are individuals we could identify and ask them to participate in an experiment and try to determine whether or not rheumatoid arthritis might be a signal that the immune system is actually working, unfortunately in a detrimental way, but maybe in a positive way.
Can I ask a follow-up to that?
Yes.
What advice would you give a young 20-something-year-old who has Li-Fraumeni, has never had a cancer, but has a mass on their hand and has been told it's probably due to rheumatoid arthritis, but they won't biopsy it? They're doing ultrasounds, they're doing, they've done x-rays, okay. So it's kind of just the person, this young adult is in a standstill, and there is no one will say, they won't even biopsy it. So she's walking around with we don't, a cyst, a tumor, who knows?
It's a very hard situation because when you look at exams and images, usually the people who do it, they are able to recognize what type of cyst that is. But my concern is that we have been surprised a few times in Li-Fraumeni with images that look clearly like a lipoma, for instance, and actually they were a liposarcoma or maybe something else. So I'm not the good person to answer that, David.
Is it dangerous to do a needle
Yeah,
biopsy?
I mean, it's hard without knowing the total context. I
No,
don't think we
that's-
want to make any
yeah.
medical judgments.
Sorry.
I can't make a recommendation one or the other. I think the only recommendation that we could make with that kind of story, and it goes for any, whether there's a lump here, a lump there, is you have to have it followed it up. There needs to be dedicated imaging. There needs to be then a medical decision based on that. I mean, that's even outside the context of Li-Fraumeni syndrome, if there's something there. So without touching on that particular case, because we just don't know what you think, the message is to get, Kim might be able
I just was
to
wondering
clarify.
if tumors, not tumors, cysts, like if anyone has a cyst, I guess this is a separate question, a cyst or a mass.
Yeah.
If someone says, we want to do a needle biopsy, could that, in general, someone had told me once, because I had breast cancer, well, if you puncture, a cyst or a tumor, a cyst, that it could make it spread or release.
Yeah.
So I'm just curious in general if that's something that is,
Yeah.
when you outweigh risks and stuff, is
Yeah. Well, obviously it's a very good question, and you've thought about this carefully, and I think you've touched on some important points. I don't have, without obviously seeing the scans, it's difficult to say, but I mean the one thing I would recommend, besides obviously following closely, is getting a second opinion, and getting a second opinion from someone who's familiar with Li-Fraumeni. And I'm not sure if the physicians caring for this young woman are, but I mean, for example, at St. Jude, we offer outside consultations for individuals who have, solid tumor masses, and so that can be coordinated, and it can be simple, right, where you just send in usually we like to get the referrals from the outside providers, so the issue will be if this provider doesn't want a biopsy, I'm not sure how willing they will be to, write a letter summarizing the case and providing the scans, but I mean, we're more than happy at St. Jude to do a consultation and to give that information back to the provider after we've looked at the scans. I'm sure, all of these other centers are willing to do the same thing. And I mean, that would really be my recommendation is, to the patient or the patient's family obviously has to be that patient's advocate. There's nothing wrong with getting a second opinion. And we're happy to facilitate it if needed. All of us would be, right?
Yeah.
Can I ask you a question back?
yes.
So in Brazil, we never see rheumatoid arthritis. And I always got this question from Pierre. And I was wondering if you could get from all those people at least what mutation they had. Because Pierre kept insisting on super trans mutations that would be related to those kinds of mutations that had specific characteristics. So in our point of view, that would be a good thing if you can tell
Absolutely.
any one of us what are your.
Yes.
Okay, thank you.
Jerry?
For the immune system, that's a very important point because we're genetically very diverse. And one place we're very diverse is in the immune system's capabilities. It's really quite remarkable. Everybody here has a different immune system. I mean, so even though we might even have the same share with our children, the genetics and so forth, the immune system is really quite different, and because it develops after, well, fertilization and so forth and so on, and it's genetic, but it develops after. So in Brazil, the HLA types, the type of individual's immune system is different actually. There's a heavy Hispanic and Caucasian from Europe influence, right? And in the United States, it tends to be European and so forth. So what, in this case, in discussing the immune system, what happens in Brazil could be completely different than the United States and so forth. That there are sort of, that's where genetics comes in heavily and has a local effect. And
I was just going to add from the basic science side of things, each of the mouse models that have the inherited P53 mutations, so the 175 mutation, the 273 mutation, even the 337 Brazilian mutation, all of those mice develop signs of inflammation. And so the mouse models are telling us there could be this possible connection between germline P53 mutation susceptibility to inflammation.
Thank you. Thank you so much.
Yes. Yeah.
I promise. Oh. Okay, can you hear me now? Okay, so I just was recently diagnosed with multiple primary tumors and multiple primary cancers, and 1 month ago I had never even heard of Li-Fraumeni syndrome. So I have to make a decision of where to go in the United States for treatment. And I don't know how to make that decision. I don't know what criteria I should be using to choose a hospital. I'm concerned that my local hospital, even though it's a good hospital, just doesn't treat that many Li-Fraumeni patients, and like the radiologists aren't probably used to looking at imaging through that lens. What criteria can I use to choose a center to go to, and then also, like, would I be eligible to go to the national? Some people here have mentioned to me the National Institutes of Health. I don't know. I don't know how to make this choice.
Where are you from?
I'm from Michigan.
There you go.
So I'm not an American, but I can comment on the NIH. So the NIH is not a treatment hospital; it's a research hospital. So they can, you can be enrolled in the study there, and they can give you recommendations, but they wouldn't give you the treatment, but they could study you and help you.
Okay.
Yeah.
Yeah,
I
maybe Kim and
know
then
Jen's giving a hug right now, but I'm almost sure that through the LFSA website, Jen has collected the names of physicians, across the country who are experts in LFS or, are willing to see patients with LFS. So Jen can probably speak, to physicians in the Michigan area. The genetic counseling community also is super tightly connected, right? So my counselors know counselors across the nation, and they can also help find, places where there is expertise.
And,
and in actually, I mean, Ann Arbor, of course, is in Michigan, and it's a
Yeah,
powerhouse of genetics. It's a powerhouse.
I wanted to rush in. So I will give you the name of a person who heads the cancer center at the University of Michigan in Ann Arbor. He is not a specialist in Li-Fraumeni, but he's brilliant. And so his name is Arub Chanayan. And so
Can you spell it?
yeah, I can't actually. So, but we will Google him and get the right spelling. Okay. But he runs the cancer center, so he would be the person to start. And he's very very sensitive.
That's the genetic counselor from Ann Arbor.
Oh, okay, so that will be a good connection. It's an excellent cancer center. I do not know what they have in the way of specialties for Li-Fraumeni, but I do know that this is a person whose advice would be terrific
I
to
agree.
get.
The University of Michigan is a tremendously great hospital, and it's also my alma mater. Michigan happens to be my alma mater. It's where I, decided to become rich by becoming a primary school teacher. But still, I'm not sure that Michigan particularly specializes in Li-Fraumeni or uses the Toronto protocols or has radiologists who are accustomed to reading, scans done for Li-Fraumeni patients. So that's kind of where I'm.
Well, I even hesitate to tell you that his specialty is prostate cancer.
Yeah.
So, however, having said that, he is really smart. He'll know the answers to what they have there.
Okay.
Right? I mean, it could be they have a unit for Li-Fraumeni, or they may not. And
The geneticists there, they do.
yeah.
I mean, yeah, I know that they know it, and I know that they're very brilliant there. Michigan is a tremendous center, but still, this is a huge decision I have to make, and
So just to confirm, the National Institutes of Health and the National Cancer Institute, we do have a cohort that we follow, several patients that were here. We're not open to recruitment for screening patients. We're open for the clinical cohort. We get all the information. We may help you, redirect you to good physicians, but the idea of being followed in Michigan would be really the best because it's close to where you live, and it's someone who will see you for the rest of your life. So.
Yeah, and I would agree. We have patients from all over coming through, and often what would happen, actually very commonly, I'm sure, with all of us, is an individual, is in Winnipeg, which is north of Michigan.
right.
No, they're not an expert in Li-Fraumeni syndrome expertise, but then they will contact us or one of the others. We run through everything. The radiologist will speak with the radiologist. The oncologist will speak with the oncologist. The radiologist can have the imaging done and sent to somebody who's used to seeing whole body MRI on a regular basis if necessary. But the other thing to remember, and it's usually the whole body MRI is the radiologically kind of tricky one, is in a center like Michigan, or frankly like any of the large U.S. centers, and I suspect large centers in Europe, is that technology is used actually for quite a large number of diseases. It's not just for Li-Fraumeni. So whereas an institution might have, a half dozen or a dozen patients with Li-Fraumeni syndrome, cumulatively they may have many dozens of patients or more than dozens, scores of patients having that kind of imaging done. So they are actually used to it. Not so much in a small center, of course, but in any of these large academic centers, the likelihood is yes now.
Thank you. That's helpful. Thank you.
I would just like to comment that I know of families that are followed at University of Michigan, and they've had excellent care. I don't know the structure of their setup. In other words, a named Li-Fraumeni syndrome clinic, but I know that people who have been followed there have been followed appropriately and managed well.
So I'm going to tell you a very quick anecdote, which is actually quite amazing. So the very first family that was actually reported in the original article connecting P53 and LFS was actually from Michigan. I didn't know that because it's all blinded and so on and so forth, but they actually were a Michigan family, which Fred Lee had told me after. But the most remarkable part of the story is once, it had to be years later, it was in the airport, actually in Boston, going back to Toronto, and there was a family sitting there, and people, sometimes people do talk in the airport waiting lounge. And they, I don't quite know how it came up, but they said, "So where are you from?" I said, "I'm in Toronto going back home." I was probably because we were like 5 hours late, so people do start talking. And "Oh, what do you do?" So it's sort of a little bit of what I do. I said, "Where are you going?" I said, "Well, we're going to Toronto," and then we're driving back down to Detroit. "Oh, cool. Where you live in Detroit?" "Yeah, we live there." I said, "Oh, what do you do?" I said, "Well, they were actually in Boston just getting a follow-up for they have cancer in the family." I said, "Oh, that's kind of cool." It was the same family. It was the family. I mean, the chances of that are spectacular. So it's quite cool. So things happen in Michigan.
Okay.
You're good. Yes.
Yes.
I was encouraged to see last year that the FDA approved Nerlynx or neratinib for preventing recurrence in HER2-positive breast cancers. And I was wondering if you think there's any hope for a drug like that or any research happening to use that to prevent HER2-positive breast cancers, similar to how hormone therapy can help prevent estrogen-positive cancers.
We need Judy Garber here.
Limitations to what doctors can do.
I actually don't know.
Yes, I mean, they're looking at HER2 as a target for like vaccine therapies, but we don't know in other cancers as though HER2 is the aggressive driver that is breast cancer. And we see it in gastric cancer. There are cases of lung cancer that's HER2 positive, and some patients even with Li-Fraumeni that have had HER2 positive lung cancer. But is it the primary driver of that cancer? So it's an interesting concept, but I don't think it's representative.
Yes, yeah, back.
My first primary cancer was osteosarcoma of the right mandible, the jaw. Just before the appearance of the tumor, there was sort of a massive impact, sort of fell and bumped my jaw pretty good. Days after that was the first appearance of the tumor, and it grew quite fast. Over the years, in support of other patients, I've noticed a pattern of some sort of trauma to their area. There was other, especially osteosarcoma to the femur and other things, softballs hitting it and different things happening. Is there a pattern there? Is this a coincidence? Or, should be walking around in goalie pads? Impact to the area causing rapid tumor growth, both in osteosarcoma and also I've heard stories of this even in soft tissue sarcoma. Yesterday I heard a story about a similar impact, but I haven't read anything on this. So just your take on trauma to the area causing the sudden appearance of these tumors.
Sure. Arnie's taking this one. Cool. Okay. And then Kim and I and
I don't have a license to be a doctor.
but he's acquiring one really fast.
Let me say, when researchers look for models for cancer in human beings or other systems, one of the models that comes closest is wound repair. All right. So in fact, as we watch the repair of various wounds, be they cuts or traumas like you've described, we notice that the body's gearing up to do a repair process and you heard this in some of the talks, with stem cells that start off by repairing and making new bone or making new skin and things like that. And the process is modeled very close to what we could see in cancer for the metabolism of the cell, the use of glucose there's a very high use of glucose in wound repair. It's one of the reasons diabetics, type 2 diabetics, have poor wound repair, is they can't use the glucose, for example, and they will get a cut and it would last a long time and things like that. So it turns out there are very striking similarities. Now, it's a bit of a leap to then say that the repair process itself just continued and developed into a cancer, because there are additional mutations and a number of other things we see in the cancer that you don't see in the wound. The wound is a limit. It's been called a limited cancer in the sense that it grows back in, but it stops. Right? It knows when to stop, right? And the cancer doesn't know when to stop. And it's that jump. Now, whether or not Li-Fraumeni families and P53 mutations have trouble stopping, that might be one way to interpret it, for example, have trouble stopping in a wound repair, has not been investigated very clearly and carefully about. I don't know, in fact, I know of none papers of people studying wounds in the mice, for example, that have Li-Fraumeni syndrome or things like that. But your suggestion is worthwhile to try to get back into the lab and ask that question. Do the wounds have trouble stopping, and do they overgrow and things like that? Because one of the things P53 does is respond to trauma. It responds to stress. That's what the gene's made for. It's what the protein is made for. So you put forward something that could be correct, but I don't think there's any research or evidence that either supports it or denies it right now.
So I'm going to let Kim and Christian talk to the clinical side, but just to follow up, you just gave me a really cool idea. So we actually, in one of the studies, there was a couple of posters where we have Gigi Lozano's mice, and they're developing tumors, but we're also imaging them every month, and we're drawing plasma circulating DNA every couple of weeks off of the vein in the leg. I say we, I'm not. The thing is, if the image starts showing a tumor, then rather than sacrificing the mouse at that point, because we want to see the progression of this thing, we're actually doing a little operation to taking it out of biopsy, and so therefore we're actually creating a wound, because then we sew it up and wake the mouse up and continues on until whenever. So we could actually do that study. We could actually forget about the tumor. Cool. Okay, I'll let these guys go on to the other side.
So, my opinion is a little different. I think it's a coincidence. How old were you when you were diagnosed?
24.
So actually, when you have little kids who develop a tumor, that's actually quite dangerous, because children get bumps all the time, and often a tumor is not diagnosed because they say, I had a bump and my leg hurts because I was playing soccer, and then the diagnosis is delayed because everybody thinks it's just a trauma. Kids and young people, that are active, they get bumps all the time. And if your theory would be true, then we would have to be careful with children with LFS. They should be very careful, not participate in sports. I would do the opposite. I think it would be important to be as active as possible. And it could be in theory true that you're right, but there's currently no evidence at all that this is correct. So I would say it's a coincidence until proven otherwise, and I would just let your kids play and be active as much as possible.
Just to follow up to that, because and I appreciate your advice. Yesterday you gave me that active lifestyle and healthy lifestyle. A lot of us are looking for consistent guidelines on diet, on what, a lot of these people, we're all jumping out of airplanes and doing different things the way we live our life at this point. Is there a consistent guideline, or is there research being done that proves, hey, you shouldn't eat red meat or whatever? I've heard all different advice from nutritionists to doctors on what a Li-Fraumeni patient should be doing day to day.
There are no guidelines, but we know, for instance, that red meat increases the risk for colon cancer. So why eat red meat? We know that you can eat a steak a week. That won't cause any problem to you. So just go on. Healthy life I think it's the best advice you can have. A lot of fruits, a lot of vegetables, increase the fiber in your diet, be reasonable in everything you do. I think this is the only thing we know now. It's very hard to conduct studies on nutrition and to really get correct information on what the patients are eating. And we have a reduced number of patients. You would need a huge number of people giving precise and on a long basis information for us to really know what's going on. So be reasonable. That's the best. But I would like to talk about the lesion and the tumor. I have always been taught that exactly what Christian just said. Don't make the connection. But so many patients came to me and said, I was playing football, I was playing soccer, and I was hit in my limb, and I found a tumor. And the most striking thing was one of my patients who got a blood drawn here. Everybody in Brazil knows that patient. She was the biggest advocate. She was the one that was presented by Chang with 19 primary tumors. The last tumor she had was discovered after she had the blood drawn. She got a hematoma in the region, and she called me and she said, I don't know why this hematoma is not leaving. I don't know what's going on. And I said, okay, that was 1 week after she got the blood drawn. I told her, get an ultrasound and come next week to see me. She was far away from where I used to see her, so she came the next week, and the lesion was already twice the size. So I think the most important thing is be active, do a lot of exercises, have a healthy life, but be in touch with your physician. And please really pay attention to anything that is strange to you. There's no over concern on Li-Fraumeni patients. You have to really establish a good relationship with your physician, with your counselor, or anyone, a nurse that you really feel comfortable with. But have her telephone number and contact her whenever you're not comfortable with what's going on. And this is valuable for maybe you reach 80 years old and you'll never have a tumor, and you'll have to go 80 times to get a whole body MRI and to get your exams. That's so stressful, that's so impactful to your life. So try to make it as nice as possible so that you won't give up in the middle of the way.
Kim, did you have anything? Or?
Oh, I think everyone's more or less covered the controversy. I mean, I think that there is no exact answer. I would not believe that the trauma causes the cancer, but I do think it's possible that if there was a lesion there, maybe if you got a wound, there would be an increase in growth factors. When you get a wound, there's something called fibroblast growth factor, which is secreted. There are other chemicals that your immune system produces. It's possible that that could increase the size of the tumor and bring it to attention. But I do agree with Christian. I just don't think we know enough to have the answer, and I think studying it is extremely worthwhile. To get back to your question about, diet and other modifications, I mean, I wish we understood more. But all that we can say, I mean, this is what I tell all my families, and you all know this too, right? Absolutely, sunscreen, a hat. Avoid excess sun exposure. Avoid use of tobacco products if possible, right? Try to be moderate with alcohol intake. I know that, we all like to have alcohol, but technically that's also potentially problematic. But trying to live a healthy lifestyle, eating a balanced diet with lots of fruit and fiber. Yeah, exactly. So the tobacco, no smoking, sunscreen and a hat. At least for right now, that's really the best I think that we can all say. I'm hoping in the future we'll have something better to say, and that we'll even have, potential preventive drugs, as was brought up before, that we could all take to prevent cancer. But right now, I don't think that we know enough. I don't know. Anybody else?
Okay, a couple of hands that's moving around the room. Yeah, maybe.
Good morning. My question is around clinical studies and the fact that often LFS patients are excluded from clinical studies. So I'm not exactly sure what my question is, other than I'm wondering if there's anyone looking at that, or if that's in your eyes, a legitimate exclusion criteria, because often, as a woman with metastatic breast cancer, clinical studies will become important at some point. So it's a bit of a double-edged sword to have this LFS diagnosis that came at the same time, because, it's catching things that crop up along the way, but I don't know what to do about the clinical study issue.
Yeah. Seeing as we've chatted a little before, so I'll move.
When I moved to the States, that was something that was very hard for me to understand as well. But you have to understand that for clinical studies, you have to have these criteria in order to get accepted in the ethics committee. And once you start a study, you really have to follow it. It's part of the deal. If you don't follow it, it's just not research anymore. And the money you get to do it needs to be included in these criteria. And the number of patients is a very definite number. So once the person is not in those criteria anymore, they just cannot continue to follow, because if not, the study is not going to be done correctly. And there's another thing, which is clinical assistance. And that's what we do in that's what I do in Brazil, for instance. I'll always see a Li-Fraumeni patient, regardless if he has a tumor, he doesn't have a tumor, how old he is. And that's what any physician likes to do. But unfortunately, under a research basis, sometimes you just can't continue to follow that patient, and you have to say, well, unfortunately, now the study is limited to those people, and you'll have to seek someone else to follow you. It's very hard. You have to understand that for us, it's very hard to say that. And for me, it was a big impact when I learned that I would have to do this here in the States. But it's not the blame of the institution or the physician. That's just how research is. And there will be a physician that will, let's hope, be able to see you, and you have to get in touch with LFSA to see who is the good person to continue to see you.
I think, though, the question you're asking is a slightly different one, is why is it that an LFS patient with metastatic breast cancer would be excluded from a study of metastatic breast cancer in and of itself? And I think it's a very important question, because we do have exclusion and inclusion criteria for many, many, many reasons, and many of them, they're all legitimate. But there's an example in the pediatric space which has changed practice, where the exclusion it just wasn't excluded, it was sort of an after the thought. So there's another genetic disorder, disease called Beckwith-Wiedemann syndrome, which is a hereditary, it's all in kids, they tend to be very big at birth and a variety of other things, but they have about a 10% risk of developing Wilms tumor of the kidney. It's a substantial risk within the first 6-7 years of life. Wilms tumor of the kidney is rare, it's almost unheard of in adults, but it's reasonably common pediatric cancer, I suppose. And there are clinical trials that have been going on for 30 years. And patients with Beckwith syndrome were enrolled because they can also get Wilms tumor. So if a kid with Beckwith syndrome ended up with a Wilms tumor, they would be put on the study. And what is actually interesting is it was found that if a patient with Beckwith syndrome has a tumor and the study arm is what we call stage 1 or a 2 tumor, just take it out, the overall survival in those patients without Beckwith syndrome, just sporadically, is about 99%. But in Beckwith syndrome, it was about 85% because sometimes it would come back. And it became apparent, well, of course it came back, because every cell in the kidney was at risk of developing another tumor. They didn't change the genetics just because you took the primary tumor out. That kidney was still at risk. So those patients, the arm changed, and they have a separate treatment arm, which is they actually get, I think it's 10 or 12 weeks of very light, quotation marks, chemotherapy, and the survival rate shot up to 99%. So you learn an enormous amount. And I think actually you have a very point is, and it's a complex question, why is it that we exclude, whether it's people with Li-Fraumeni or other disorders? There are reasons we go through, but I think as we understand more about the disease, it behooves us to influence these clinical trials, the folks who are designing the clinical trial for breast cancer, for whatever it is, to be sure that if there's a reason why they're being excluded, what exactly is that reason? And I'm not entirely sure I always understand that there is a rational reason for it. I'm not the breast cancer guy, but I've talked about it with Judy Garber, for example, and there are challenges with designing the study, but I'm not so sure that it should be excluded entirely. So I don't know.
I once wanted to say that one of the really special things and great things about having an organization is that someday there will be clinical trials for Li-Fraumeni patients. And the reason why there probably aren't is it's just been hard in the past to collect Li-Fraumeni patients in enough numbers to get statistics, but an organization like this really can promote the patients to come in and know them and identify them and so forth. And so it makes a higher probability that there will be. And given the frequency of breast cancer, for example, that might be a very interesting target for a particular drug in Li-Fraumeni families.
Rob, did you want to say something? Yeah.
Yeah. So that being said, LFSA standpoint, we did get emails from all over the world regarding the trial for LFS, and it's sort of our mission to encourage you to pursue trials, because it's often the most promising therapy. And yes, there are some blanket statements excluding people from, say, metastatic breast cancer trials, but they're often not as hard and fast. Those exclusionary criteria are often not absolute. And so when you talk to the study coordinators, I find it hard when thinking about metastatic breast cancer and many of the other adult tumors that they're going to specifically point out Li-Fraumeni. And the other thing we're seeing is a little bit more of a loosening of the history of prior cancer within the last 5 years, because I think that's the biggest problem for our patient population. And so even that particularly is not always hard and fast. So I would say talk to your study coordinators, talk to your doctors, and sort of push. So.
Yeah, sorry. Go ahead. I'm trying to get spreading it around here.
Actually, yeah, my arm is hurting. I'm actually asking for her. She's shy, so I'm not asking for myself. We were hearing Dr. Levine about the immune system, and the thing is, my father had melanoma. He's not a Li-Fraumeni patient. My mother had many tumors. But the thing is, he got treated with interferon, and she was wondering if there are some studies that can use interferon in LFS patients to improve their immune system, so that might help somehow. I don't know.
So interferon is part of the immune system. When I spoke about it, I left it off because it's part of another part of the immune system called the innate immune system, the ones that come to us that we all have the same inherited way. And it stimulates, actually, the immune system to activate. And it was thought in a variety of interferon trials that this would be a good stimulator. It's a particularly difficult treatment to have because it has lots of side effects that are pretty unpleasant. And many people take themselves off various studies of interferon because the side effects are really pretty bad. However, there are other stimulators now of the immune system, or even stimulators that include the stimulation of your endogenous interferon, the ones that you make yourself rather than inject it in things. And I think what will be happening, in fact, I know what's happening in the pharmaceutical industries today. There are over 800 trials, maybe 1,000 trials, that are going on for cancer patients and immunotherapy. And the attempt is to get the number up from about 20 to 30% responders to the therapy up to 80% and 90%. And we're going to learn a lot about what will help stimulate the immune system. This is a real study going on right now in the clinical trials on the regulation of the human immune system. We know a lot about the mouse immune system for obvious reasons, but it turns out it's not really like the human immune system in every case. And so I have a lot of hope for the future that they maybe come through things that will stimulate the immune system. And again, I have a lot of hope that there'll be enough Li-Fraumeni patients to go into clinical trials and that the immunotherapy will come in. Li-Fraumeni group is a group having a p53 mutation at conception, essentially, and birth really means that the immune system would tolerize against it. It wouldn't see it, right? And that was the question David Lane actually asked me yesterday after my talk. And my answer was that we'll learn that. I mean, we'll find out if you can break that tolerance. We'll find out these things. That's why I have a lot of hope in the immune system is just being used extraordinary. It's probably the most common clinical trials, that and gene therapy are the two that are going on in the population of cancer patients in general. And it's very natural, I think, to flow into the Li-Fraumeni population. And I'm very hopeful that that would be something that would work.
Thank you.
Yeah. Could you just turn your thing off?
Yeah.
Sorry. That's great. That big. Yep. Well, there you go.
Could you speak to breast MRIs in the post-mastectomy LFS patient population? I've heard anecdotally, myself included, of several females who have developed breast cancer after mastectomies, and the recommendation is not to have a breast MRI because the surgeon supposedly got all the breast tissue out, but there's no post-surgery MRI to prove that.
This came up in one of the surveillance things. Again, you've got a bunch of pediatric. Rob, do you have anything?
We discussed this yesterday in the surveillance session too. Yes. Sorry, we discussed this yesterday in the surveillance session too, and yes, there's a risk, and Dr. Garber, I think it was, commented on that, yeah, there's a concern that patients have had inadequate surgery if they have recurrence, but as a standard of practice, we don't normally do that in BRCA 1 or 2 patients. In patients with Li-Fraumeni, I'm not aware that that's a recommendation for anyone. What I would say, though, is like anyone with a history of breast cancer, I think vigilant surveillance is important. I mean, particularly exam. And we're privy to these stories from all over where, forget breast MRI, if someone was aware and doing a good exam, may have found a recurrent breast cancer. So, sorry, I can't answer any better than that.
So, I have a question. You said your Wilms tumor, they have that second arm that has cells, with whatever.
And there was still cancerous cells or kidney cells that would make cancer again. Would it stand to reason that every breast cell that we have is more chance of having?
Right. So that's so conceptually, in Li-Fraumeni syndrome, whether it's Beckwith syndrome, any of these situations, every cell in the body carries a mutant abnormal copy of the gene. So removing in the Beckwith the left kidney, the right kidney is genetically the same as the left for all intents and purposes. So for patients with Li-Fraumeni, a reason why they appear to be at risk of a multitude of tumors is because every cell in the body, by definition, carries an abnormal copy. So whether it's a bone or a breast and so on.
So surgeons leave behind approximately 10% of our breast tissue. Therefore, yeah, you lowered the risk a lot, but I would argue that whoever is in charge of creating the protocol, and I don't know who that is for the adults, that they would highly consider including breast MRI. And I don't know who's
So breast MRI is included in the protocol.
After double mastectomy, after any,
I don't know
that it would
if,
continue for life, I guess.
Yeah.
So the protocol is made for people who have not had cancer. So if you had a cancer, you need to combine the protocol, which is basically a surveillance protocol, for the follow-up, with the follow-up protocol. So that doesn't mean that if you use the Toronto protocol, you don't have to do follow-up. So once you had cancer, you need...
Follow-up in the United States is that you would not receive any scanning post-breast cancer.
It seems to be standard.
That standard of care in
that has ever had a double mastectomy. We do not get any scan follow-up. It's only manual breast exams.
Right.
Yeah, I mean, it's yeah.
No, I mean, I don't know very much about it, but I guess the question too is, obviously, if there is 10% of the breast tissue left, I imagine there is a small but real risk of a subsequent recurrence. So, I don't know if there's anything in the literature yet that reports what the risk is and how often it happens. So it may be one of those things where we have to collect information. We have to publish this isn't going to be satisfactory, but that we have to publish the information. It'd be a great thing to try to collect. Yeah. So if this is the, yeah.
What did you say? Raise your hand.
Raise your hand if you're a second breast cancer
After double mastectomy?
After 30 years.
Yeah. So this is really important,
That's
David.
important to know.
Yeah, but so you guys have brought something really important. I'm getting goosebumps actually because it makes me feel terrible. But I think that this is a very important piece of information, and we need to collect this information and we need to publish it and put it out to the literature and try to raise awareness and see if we can use this to
Right.
consider changing policy and practice. So I wasn't aware, as a pediatric oncologist, that this was even an issue.
So I
But
think
David-
it's easy enough for us to do in a sense logistically because we have experts in the in the group, in the Li-Fraumeni group, including folks like Judy Garber and Jeff Hartzell and others who are in the adult breast cancer side. But that's what they do for an academic living. They are very much part of the development and the ongoing evolution of the protocol. There's no problem working with them, and I suspect that could be done pretty quickly. It does go to the question both if it should be done, how, and so on. But as Christian's pointed out, this is critical almost regardless of what the primary tumor was, because I've had this also from other practitioners. So once the child gets an osteosarcoma, then all of a sudden they're stopping doing everything else. It's like, just because you got this tumor doesn't mean you couldn't get another tumor. And so, as you said, the surveillance continues regardless, and then you just add on the follow-up, whatever that should be in the field of that disease discipline, osteosarcoma, brain tumor, breast cancer. So it sounds like we need an education, perhaps, not just within the Li-Fraumeni clinical community for sure, but also actually in the breast cancer community, which is way larger than than us, right? So, and it'd be interesting. I don't know what it is in the BRCA1 and 2 carriers. Is there an increase?
Yes.
There is. So do they get follow-up?
The exact.
Either.
No, they don't do follow-up MRIs. But I don't know what the percent. If we had a room with women that had BRCA and had double mastectomies for prevention, there is an occurrence afterwards at a certain percentage, because breast tissue is not 100% removed. And that's the same thing as you've said, but with BRCA, there's this high probability, and they have the exact, I don't know if the percentages would be the same if BRCA is slightly higher risk than Li-Fraumeni is, but it would, for very reasonable reasons, it would be the same, exactly the same, it's a inherited predisposition.
So when you do bilateral mastectomy, there's a very important thing is who does your bilateral mastectomy? There are several surgeons, mostly those who did it several years ago, who leave a lot of tissue. Why do you leave tissue? It's because your skin needs to have blood supply, and you need at least a little bit. If not, you increase the chances of necrosis and all the complications that may arise from bilateral mastectomy. So what we hear as geneticists working with oncogenetics and having to deal with these situations, the breast surgeons, what they say is that most of the recurrences or the new primary tumors occur on top of the implant. So they would be detectable by self-exam. So on our side, what we do is to really encourage the woman to do a very detailed auto exam so that they can find these tumors early and get them removed as soon as possible. That they would take as long as you would have to see on a new magnetic resonance of the breast and auto exam. So
That's great. Thanks for bringing that up, though. Obviously, it's critically important that we figure out a way to resolve it. We'll have to engage the breast cancer research. As a pediatric oncologist, I might be talking a lot more with my adult oncology colleagues, so it's good.
Can you give us some reassurance and timeline? Should you guys leave here and go and talk
But speaking for myself, I'm probably going to leave here and go to sleep. But we'll be on it. Yeah. No, it's an important factor. Pardon? Yeah, it's the database.
Make sure we coordinate efforts with our medical advisory board and everyone. And same with the trials and everything, just we do post those on the website if there's something specific you're looking for. We can also reach out to our medical advisory board and make sure if there's any available. We can also, if there's something specific someone is looking for, please let us know because we can reach out and we can find out what is available.
That's
Thanks,
a suggestion so in the breast cancer world, you may know of Dr. Susan Love. She started something called Army of Women. I don't know if many of you have heard of that, but we can get emails from Dr. Susan Love's group saying, we're doing a clinical trial on women under 30 with HER2-positive breast cancer. I get a direct email to see if I can participate in that trial. So we're here. You see this room full of us bringing unique opportunities for clinical studies, research, genetic, so on and so forth. You know, the wheel doesn't have to be reinvented, and you guys could head that up as well and coordinate. But I mean, I've talked to several people here who are like, use us. We're right here. Not everyone in this room or P53 positive people may want that, but it's good to know when these opportunities come up that we can then coordinate with you and you can use us. So, and you could.
Also, even because clinical trials have so many restrictions and are so tightly controlled, in these days of social media and crowdsourcing, you can collect a lot of data, even if you don't do a clinical trial. With a source like that, you know, just people self-reporting. If somebody just put out, you know, and I realize self-reporting can't, I mean, have the accuracy of a clinical trial and things like that. Still, it could be a lot of information.
And sometimes it's just, and sometimes it's just filling, when the emails come through from Dr. Susan Love's groups, sometimes it's just filling out a survey that's attached even, you know, and sometimes it's a way for grad students too as well to reach out to us. And I know many of us, again, are willing to just take that 10 minutes to fill out that survey that can then help you guys further. So if you want to look in some of the things she's done as an example.
Great, thanks, for sure. I know it's got a couple of new people and come around. Yeah.
Let's see. Just have a question if you've seen in any of your practice a correlation between LFS or positive P53 mutation and seizures. I had infantile seizures, and I know another family or two has had experience with seizures in the family while also being LFS positive. I'm just interested to know if you've seen any correlation.
It's a good question. I mean, I can wait. I mean, we have occasional patients who have had a past history of infantile seizures or something of that nature. It happens also in the context of, at least in our practice anyway, seizures of one sort or another are extraordinarily common. It's amazing when one has a family member who develops a seizure or has a seizure, and then you think, oh my gosh, and then you find out that like 1 in 100 people or less. It's actually an interesting question because we juxtapose a relatively uncommon disease, Li-Fraumeni syndrome, with a very common condition, i.e. seizures of some sort, and trying to make correlations then becomes really challenging. So I'm not saying that there isn't. I don't know that anybody's ever studied it, unless Christian, maybe you have.
But on the other hand, I mean, I would totally agree with you, but it could rarely, of course, be also associated with a small lesion in the brain, that, and therefore that needs to be ruled out. If it's the first time, then you should definitely see the doctor to make the oncologist to rule out that there's like an underlying
Absolutely. I think you were referring to if you've had a past history and then, so whether the correlation of P53 itself and the various, there's a lot of different seizure disorders or forms of epilepsy. I don't think that anybody has looked, I don't know. The mice don't seem to get seizures, do they? I'm not saying that jokingly, totally. Huh?
So you guys need to collect them from the streets that they're actually like in like the environment and went through like horrific experience and then
The mice or the people? Oh, the mice, okay.
Rats in New York.
The rats in New York.
It's more accurate
I'm sure there's a graduate student it'd be good to go into the sewers and. Yeah. That's a good question. It's, yeah, question up there.
Oh, hi, thank you. So I was just wondering, as we heard so many PPPC drugs and develop research protocols for yesterday. I was wondering how could the panel comment on how could the LFS and the somatic PPP3 people mutation people actually see these drugs, and is there any differences in or common or any guidelines or future outlooks on those? Thanks.
I'm not sure I understood. Yeah. Can you clarify? I'm not quite sure I understood the question.
So I was wondering if it's all about the PPP3 protein, PPP3 mutation. However, Li-Fraumeni people got it like when they were born, and the vast majority of people who carry PPP3 mutation are somatic, and who acquire it afterwards. I was wondering if the two populations should see the drug differently, and should the research also be directed differently towards the two?
Okay.
Thanks.
So we've learned a tremendous amount about P53 from the general population, and they acquire their P53 mutations, as you've said, spontaneously in a particular tissue and at a particular time. But there is a significant difference in the timing. Probably the best example that's been studied that I can tell you about is colon cancer, right? And you'll see, what I'm going to do is to sort of take you through the mutations that are found in colon cancer in the general population first, right? And what their frequency is, right? So as a generalization, all the studies that we have three groups of studies, they all agree that in colon cancer, the first mutation is a mutation it can be inherited or it can be spontaneous, but it's always the first mutation if there's going to be a colon cancer at a fairly young age. And that's called the APC gene, or the adenomatous polyposis coli gene. And that makes a polyp, these benign polyps that you'd pick up in the colonoscopy and are taken out. And they're benign, but they're a precursor to the cancer. And the second mutation occurs is called the RAS mutation. And that makes a bigger polyp. And the third mutation that occurs is called the TGF-beta mutation. I'm a teacher, I'm afraid. I'm sorry for teaching you too much. A TGF-beta mutation, and that makes a larger polyp. So they're all benign at this particular point. And then the last mutation that makes the tumor malignant is a P53 mutation. So it's a pretty devastating mutation in that regard. That occurs in about 60 to 80% of colon cancers in the general population, the P53 mutation. Right? Now, that's true for all of the parts of your body that are inside. Your prostate, your colon, your small intestine, your pancreas, your lungs, all have very high P53 mutation rates of the spontaneous population. They all occur late in the tumor process, and they all are often mediating the transition to malignancy. So you can immediately see that in a Li-Fraumeni patient, the reverse is true. The first mutation is P53, and the common kinds of tumors you see are sarcomas and things like that, and breast tumors, right, where it's just almost the opposite. It's been an enigma for a long time. It's almost the opposite in the frequency. We don't see in sarcomas in the general population very high P53 mutations. In breast cancer, estrogen-responsive breast cancer, ER-positive breast cancer, doesn't have a high P53 mutation rate, but triple-negative breast cancer has a high rate, and it's the estrogen kind that are generally found in the Li-Fraumeni population. So that's been a puzzle to us for the longest time. And I and two other people at MD Anderson are just writing a paper to try to explain that puzzle. And the explanation is almost inherent in what I gave you. It's what's the first mutation. The first mutation dictates the subsequent ones, and it gives rise to different tissue responses. So there are differences between the spontaneous general population and the Li-Fraumeni population. However, the function of the gene is still the same. And that's why the warning about radiation, things like that. It's all stress responder. But this is one of the things that we've learned in cancer because of the Li-Fraumeni population, right? That the order of addition might be the order at which you obtain the mutation might be a very important variable. And it may mean that, in fact, people have often said that the fact that Li-Fraumeni patients respond so well to therapy in many ways, that may be, again, due to the order of the mutation and things like that. So, though I don't know the documentation about responses. So we're learning a tremendous amount from comparing the two populations. And like anything else in biology, unfortunately, there are very strong similarities and very strong differences between the two. But everything teaches us something. And there's going to come a day when we'll understand it all. I just hope I'm here.
Question? Or Kim?
So actually, although it's bad that P53 is so often mutated, it's actually good for the LFS community because it's one of the most important genes mutated in cancer in general, so many people are working on it. If it would only be mutated in individuals with LFS, then nobody would really work on it because it's a rare disease. But because it's one of the most important genes in cancer in general, many, many people work on it. And therefore, I am quite convinced, also listening to the talks, that there will be drugs that somehow target a mutant P53, and this will be a hope for individuals with LFS, because once these drugs are ready to go, there will be also trials for people with LFS.
But one of the things, just to follow up that briefly on Christian's point, I probably should have said this right near the beginning of the symposium, mainly for you, is so the P53 scientific research community is actually very tight and has been for decades really. And every 2 years, approximately, there's an international P53 meeting, which has on average about 400 people now, or maybe thereabouts. Sort of built up over time, and 95% of the folks who come to that and who speak at that are the basic scientists studying this gene. There's also a subset, a smaller meeting called the mutant P53 meeting, and that's perhaps half the number, and those are people who focus on the mutant format. It's not got to the point where we have meetings about specific mutations, but you never know. When I sent out invitations to the P53 scientists who don't, as a rule, work on the germline context, they're working on the gene, the protein in its grandest sense. Every single one of the scientists invited agreed. It was 100% response rate and 100% agreement. They are taking their science, which is, as Arnie suggested, has traditionally been in the massive general population of what P53 does to cause cancer, bringing it into the germline, and that's exploded this field out enormously in the last very few number of years. So it's not, as you say, it's linking these two things, which for the longest time were kind of working in parallel, but not really intersecting.
So I just wanted to follow up on what Christian said. So I would have actually, the statement I would have made is it's the most important gene in cancer, and the P53. And the reason is that it's the most common mutation in all of cancers. And this is responded with 80,000 to 100,000 papers and publications on this gene or associated proteins for this gene. Finally, the real payoff for all of us is that there are now a dozen or so biotech companies and several pharmaceutical companies that are working on responses to the mutation in the p53 gene and working on related genes that regulate p53. The farthest along is a phase 3 trial that Hoffmann-La Roche is running for a disease called AML, acute myelogenous leukemia, adult acute myelogenous leukemia. 25% of those leukemias have p53 mutations and have p53 mutations, 75% are wild type, and they have a drug that can take the wild type and make it active, very active, and kill the cells. Right? And so they're in phase 3 trials, though I don't know how close they are to registration and having the first drug on the market, but that will be one, and that would be for wild type p53, but nonetheless it utilizes the properties that are known of the gene and the protein. And these biotech companies are all over the place. In fact, I was thinking as Christian was talking, I have an appointment tomorrow morning at 10 o'clock with a scientist from Shanghai. This will give you the world relationship between the sciences, who has a drug that reactivates mutant p53 to wild type p53. Now, it's not in the clinic, it's in mice, and it's but that's what's happening all over the world. And he wanted to talk to me because he's got some questions about the drug and the development of the drug. But I think these things are happening more and more for the reasons that Christian said. This is a single most important target in cancer. It could make a very big impact on all cancers. So I'm an optimistic scientist. Yeah. So.
Yeah.
So I'm struck with just the amount of information. What did you just say, 80,000 articles? So the symposia are great. Is somebody doing an analysis of these? Is somebody, or is there like a Watson for P53 that people are putting all of the information into, that we have better, easier access to all of this so that you can...
Now for the complicated news, right? So not all of those papers agree with each other. That's the first thing. And so we'll take a bit of a human brain, not a Watson brain, at this time. Watson can collect the information and take a vote, but that's all Watson can really do. And I don't even think there's any one human being that read all 80,000 of these papers, obviously. But the truth of the matter is the way science works, I mean, I could speak for myself now, I won't speak for any of my colleagues, is you read the papers you trust, and the people you know that really do this work, and you get to know people who are really good scientists over time. Science is no different than anything else. You know, there's good science and there's average science and there's poor science. And it moves ahead. It moves ahead a little bit in zigs and zags, but it moves ahead. But I mentioned the 80,000 to 100,000 papers to give you an idea of the fact that what Christian said, that in a quantitative fashion, this is a gene everybody cares about. This is something that a lot of people are going to try to do something about.
The other thing, too, is it's the 80,000 or whatever numbers papers that sort of would put P53 somewhere in the title or close that it actually comes up. But as you've heard from a number of the talks over the last 2-3 days, there are links to other parts of the world, immunology, the mTOR pathway. So people are coming in from other disciplines and starting to link those together. And that's actually particularly exciting. So it's expanded from just the world of all of us focused on one gene or one pathway to realizing that all these interconnections probably are going to be really valuable down the road. Yeah. I mean, linking basic science of P53 to therapeutics and all sorts of things, even imaging and scanning, and yeah. So it's not just 80,000. Other questions? Oh, sorry, yeah.
Okay, so we have a healthy copy of our P53 from one parent and then a mutated copy from our other parent. Have you ever seen a situation where there's two mutated copies, like where both parents are LFS positive? Us moms here can't help but to speculate, thinking we're bringing our teens to these conferences, and what if they're mingling and some of them fall in love?
So
Would they be able to have children of their own, or is that not even an option? And if they did, what would that look like?
So it's a great question. I'm not going to comment on the matchmaking concepts here, but so there are actually a very small number of...
There's 3 in Brazil and 1 in Saudi Arabia that we know. We just found out at this conference the one in Saudi Arabia for the first time. A 60-year-old male with 2 children that had cancer, but he hasn't.
So
no, he has 2 mutant copies. Yeah. So in both Brazil and Saudi Arabia, there's a lot of inbreeding, and in Saudi Arabia especially, there's a lot of inbreeding because the Faisal family breeds in, and I just found out about. So I actually got the card of the young woman who's the genetic counselor who was here from Saudi Arabia, and. That's quite an enigma. So, but that's exactly what happens in mice. Mice are born fine with no copies, and the humans, obviously, there are 3 of them in Brazil that has been found for the same reason. In the Brazil one, they have the same mutation twice because it's the same family that's breeding. It's really an enigma to us. We always think of it as a very important protein that responds to stress. And yet this tells you the fact that you could be fine and have 2 copies, that it's not essential or there's ways to compensate for the loss of it in some way. And that's another actual approach that we think about, try to figure out, a little hard right now. But if there's ways to compensate, couldn't we exaggerate those ways for patients with Li-Fraumeni? And would that be an approach, right? Yeah. I don't have the foggiest idea how to do that right now, but I keep thinking about it.
So we've reported actually one family, quite some time ago from the States that was referred to us where the child had 2 mutant copies. One was inherited and one was presumably de novo, so the child ended up that way. And we have 3 others that we know of, at least one from Australia and a couple from Europe that we studied. So they definitely exist. I think, I recall actually, Kim, there was some discussion when I was visiting you guys, maybe not, maybe it was something else. But so they definitely are folks around who do carry 2
3 in
variants.
Brazil have had tumors already.
Yeah, so I know all of these have had tumors for sure. What is interesting is there's actually, and this Jen might remember from, I think, the very first conference at the NIH, that wasn't the teens that were brought together, but there are 2 LFS survivors who met, and love is in the air or something like that. And I don't quite know what the long-term follow-up, but at least in the intermediate follow-up, and they lived in 2 different states, right? Yeah. So, hey, anything can happen. But yeah. So
I would just add from like the practical genetic counseling standpoint, it would increase the chance of their children having Li-Fraumeni syndrome, though, right? Because we quote a 50% chance, right? Because they'd have normally it's 1 LFS parent and 1 parent with 2 normal or typical copies, right? So then it's a 50-50 shot. But if it were 2 Li-Fraumeni carriers, you'd have a higher chance, right? Because each parent has 1 working copy and 1 broken copy. So it would be like a 75% chance of them passing on, of them having a child either with 1 copy of P53 or having a child that had 2 different copies. So it would change a little bit some of their reproductive counseling. And then, of course, also, one of the options out there is PGD for the families that want to do that too. So,
can I just ask something? But if you've got the 2
damaged P53, then you will pass it on to any child you have.
Yeah.
So these people you're talking about who have already got the 2 damage, they know that their child, if they ever had one, would have.
Absolutely.
And they would, and they would have no option apart from some sort of surrogacy, would they?
That's correct.
Yes.
Yeah.
That's correct.
Yeah.
Okay.
Yeah, it would be 100%. Yeah. Sorry, can I say about that?
Is there any studies going on for the difference between people who have mutation versus people who have a total deletion or a deletion in one of the genes?
Yeah, so there are, there are a number of folks who do carry a partial deletion or a complete deletion, and the correlation of the ultimate phenotype with that, it depends a little bit on which study you look at. There's a fair bit of variety and I suppose almost controversy about what the phenotype is. Is it worse? Is it better? Is it the same? We had thought if you delete the entire P53 gene plus a whole pile of stuff on either side, so the whole thing is gone, at least in our experience, those patients do not actually get cancer. We proposed the hypothesis that the only P53 they actually have is normal, because the other gene doesn't exist at all, but they still do have that normal one, and that is sufficient to be able to activate all the processes that are required for a cell to maintain its integrity and genome stability. But there are definitely reports from all of our groups, I think, of partially deleted P53 where they definitely get cancer.
What about if we know people who have full deletions and they have had cancer?
There are, yeah, there are. It may depend on where the deletion actually is knocking out the gene. So the way that genes work is there's these exons and codons, all the stuff that codes for the protein, but there's all these parts of the gene kind of in front of it, which we call sort of the promoter, or the regulatory part, which kind of turn the gene on and make it work. And it may be that the deletion that one sees in these patients who actually develop cancer takes out the vast majority of the stuff that makes the protein, but the part that's left behind is enough to mess things up.
Kind of kindergarten 101.
Yeah.
You're saying that if someone has a full deletion, there's still part of the gene that is.
So what I'm saying is that maybe you guys can help me here. So you almost have, here's this podium. So this part is the stuff that's then translated to make the protein, which tells the cell to do what it is. Then there's this other part, which is like driving this part. If this part's gone, or most of it, but there's a little left over, and there's something wrong here, then that can change the process. I need a geneticist here too. I probably need to sleep sooner than I think.
There's different types of mutations that have different phenotypes, right? So that part that David said drives the gene is often called the promoter. It regulates the amount of the protein that's made, and it could go to 0. So it would look like a deletion because it wouldn't be making any protein at all, but the gene would be there. And then if the gene is a series of chemicals that go roughly 1,000 nucleotides along the information part of the gene. It's bigger than that, but the information part. And as you're missing, you could miss, if it's 1,000 long, you could miss 300, right? And that would be the deletion. Then you'd still have some fragment of the gene or the protein that'd be made. Commonly, those fragments are unstable. They don't last very long. They're hard to see, but they're made because the gene knows what it's supposed to do. It's supposed to make a protein that's just missing the middle or missing the end. And so mutations occur at all places and all types. So there's deletion. The first mouse mutations that were made with deletions of the whole gene. And there's actually a fairly interesting story about this. After you discover a gene and you clone the gene and you find out where it is and so forth and so on, one of the standard experiments is to knock it out in mice. And that tells you something about its function when you knock it out in mice. And you knock it out, you usually make a deletion, although nowadays we can make just exactly the same mutations that are common in human. So there was a fellow named Donauer at Baylor who made the knockout mice. And there was one of these meetings that David said about the P53 meeting, where there were 250 people that loved P53 and did research on P53. And we were all very excited about the idea that the first mouse that didn't have the gene was on the ground, and everyone was watching the mouse and so forth. And he got up and gave a talk and said the mouse is absolutely fine. There's nothing wrong with this mouse, right? And the whole place got depressed, right? Because here we all had worked for 10 years or 8 years on a gene that was not essential, right? This sort of not necessary, right? And then 2 weeks afterward, when the meeting was over, he emailed everybody and said, the mouse got a tumor, right? And that was just the waiting time to accumulate additional mutations and things. The history of this field is cycling up and down and changing and evolving, and that's just the way science works. Now we know a lot about these mice, and we can even, as I say, make exact copies that look like Li-Fraumeni and have the same mutations of some individuals in the room and what the properties are and things like that. It's getting better and better at trying to copy the model system to copy the human.
Yeah, Amy.
So I have a question about LOH and how loss of heterozygosity, how it cascades through the body. Like, is it just on a cellular level, or does it tend to be that LOH will happen in one tissue, and once it happens there, is it more likely to kind of spread? I don't know. I don't know if it's connected with telomere length, and once those are shorter, then LOH happens everywhere faster.
One of the major, so first of all, the most obvious difference in being a heterozygote is the copy number. The amount of protein that's made is usually a little bit less, right? That's a perfectly natural thing, actually, in human beings, because females have 2 X's and males have 1. So you'd think females would make twice as much of something because they have 2 X chromosomes and males 1. But the females inactivate randomly one of the X's, and so they end up with 1 active and X, and males have 1 active X. So there's a little less protein made in every cell, and that has some phenotypes that we can see, some actionable items. But one of the common events that can happen is that, remember, this is responding to stressful situations like radiation and things. And chromosomes divide and cells divide. And late in the division process, they undergo the separation of the chromosomes. And they separate the chromosomes very faithfully. So we have 23 chromosomes twice, 46 chromosomes. And they separate into 2 cells as they duplicate first, and then they separate. Right? That's late in the process of all the replication and separation. And P53 responds to stresses that actually make mistakes in the separation. So it really prevents the mistakes in the separation of chromosomes pretty effectively, and it's pretty good at what it does. It's very efficient. It's almost like the manager of a line of producing, some product, and the person at the end is watching very carefully to make sure the product doesn't have a mistake. In the case of P53, if the product has a mistake, it kills the cell. So it's actually it's keeping fidelity of the process by killing, right? And that's one of its functions. That's the stress function. Sometimes if you have a mutation that you're carrying, you make a mistake. And the number of chromosomes that goes to each of the cells isn't exactly the same. And that's called aneuploidy, right? The change in the number of chromosomes. And ultimately, the cell is some cells will die and other cells will live, but with an abnormal number of chromosomes. And that's how we think the process would start to make a tumor, at a single cell, actually. And then what would happen is that the chromosomes would make a mistake again and again, And ultimately, you'd have 2 copies of the same chromosome that had the mistake, and it would be the one that would replicate the fastest and make a tumor. And we've seen this happen in any model system that we can find. We don't, of course, don't see it in humans. Can't monitor it at that level, but we've seen those things happen, and we presume that those are the early events that are occurring. And they just occur at a higher rate in people that have one mutation already. And that's the reasons for the high incidence of cancer.
Just a quick comment. So in the childhood adrenal tumors that we study, often they're associated with the germline P53 mutation. And in 100% of those tumors that we study, they delete the wild type chromosome and then they duplicate the chromosome that has the mutant P53. So it has to get rid of that wild type P53 for the tumor to develop. And the bioinformaticists, the computational biologists, can tell us that that event happens very early during tumorigenesis, as if it's a required event. So it's seen in almost, essentially 100% of the adrenal tumors.
Christian?
But to answer your question, it occurs at one place, and if you're unlucky, this place can become cancer, but it doesn't spread from here to here to here. It doesn't occur. It occurs at one place and one cell, and this all of a sudden gives the cell an advantage to grow, and this advantage can lead to cancer. And this cancer, of course, can spread, and then it can occur at different areas of the body, but it's not that it all of a sudden occurs at several spaces or spots you get this LOH. It starts at one place, and then it can, if you're unlucky, it can become cancer.
And if a second tumor should occur, at least as we understand it, it's a second independent event. It still would be a LOH, but it's not dependent on whatever the first one was. So if the first one was in, let's say, the breast, then and another one 10 years later is an osteosarcoma, those would have been 2 separate, unrelated events.
But maybe related to something in the background.
Oh, absolutely, of course.
The
Yeah.
mechanism would be the same, but the events would be independent.
Right. So a little birdie, as you saw, tapped on my shoulder. Actually, I didn't answer right away because I was almost going to go. I seem to have a twitch going on, but very gentle. This has been a terrific session. For me, a lot of these questions have been great because I think, in a sense, the questions you've asked in the last couple of hours are the questions that we ask perhaps from a different perspective. And I think that's nice to see. There's a link. There's an urgency. I definitely got that sense. Okay, so I'll go for a nap. Maybe I won't sleep too long. I'll go for a nap. But there are a lot of important things that we need to work together with the LFSA for some of the activities and generating information for you guys and generating information there that then can be brought to us to continue to develop newer and better design experiments and studies and so on. And I think ultimately, I'd like to think is in the short term and not ultimately sometimes sounds like a long-term adventure. And I think there's obviously, don't need to tell you guys for sure, an urgency to try to address as many of these questions as soon as possible. So I think we will call it quits. I'm sure there's many other questions. We have not yet decided exactly where the next meeting will be in 2 years, but we have decided it will be on the eastern seaboard of the U.S., so it won't be too far from here, and it'll be in a place that you can actually get to easily. Kim? For sure.
So I just wanted to mention again that we'll be having a family conference at St. Jude in Memphis, and so if any of you are aware of other families who might be interested in coming to a much shorter and less involved conference, we'll be holding one, and we're willing to offset the cost of travel, so we can provide $500, against the cost of travel. And Dr. Kratz, I'm very proud, will be there to speak with the families, as well. Josh Schiffman, a local psychologist, will be there, and we wanted to make it a day for families to network, to learn about the advances in the field, and to have a little bit of relaxation and fun. So if you know of any families, you can either contact David or Jen, who can give you my email address, or it's just kim.nichols@stjude.org.
When you look at the website, it makes it sound like it's mainly for teens.
Oh, our plan originally. I do have an interest in the teens, so we wanted to have part of what we're doing focus on teens and kind of learning about taking responsibility for their health, transitioning to the adult medical care system. To be honest, we had opened originally to the St. Jude families, hoping to bring in enough teens, but as you can imagine, everyone has complicated lives, and it's summertime. The meeting will be June 8th to 10th, so the number of teens that we were able to recruit internally was a little bit lower, and so we've opened more broadly. So it can be any family with LFS, whether their children are still alive or not, adults or children. If you have teens, we have a special teen focus, but it's open to all families.
Great, thanks. Thanks, Kim. That's good. So, safe travel, safe driving, flying. Just so folks who do know, it's about half an hour from here to the airport, to the Pearson Airport. And for those who are going to the States, you do go through U.S. Customs here. But at this time of day on a Sunday, that should be a really fast process. The middle of the day is pretty fast. So, thank you all again, and see you next time.